Good evening, everyone. Thank you very much for this opportunity. You must be wondering what is a tertiary prevention guy doing in a primary prevention setting. It's because I have had the worst of the complications, and you wish that you did not operate on those patients. And that's the reason why a cardiologist should be focusing on primary prevention rather than just tertiary care or intervening once this video is of one of the complications of acute MI, not my complication, which is winking coronary sign of ventricular septal rupture in a patient of acute myocardial infarction. So basically, cardiometabolic disease itself is a big spectrum. It would encompass not only cardiovascular disease, but of course the diabetes, the conference of which it is dedicated here, but also a huge number of that would also encompass metabolic syndrome. Apart from that, there are interconnected risk factors, which we had having a session just prior to this: obesity, hypertension, and dyslipidemia. The prevalence, if you look of as on 2025, cardiovascular disease is expected to increase from 54.5 million to currently almost 118 million. We have doubled in exponentially, probably in not even just a decade or so. 77 million diabetics and hypertensive 25%. Again, as was said, if you change the numbers, if you make 120 as the cutoff for normotensive, probably these numbers are going to be even higher. So the key risk factors when you talk about is, of course, unhealthy diet, physical inactivity, obesity, tobacco use, alcohol consumption, and air pollution, which has recently been added. And I was the author of one of those papers, or GBD, Global Burden of Disease, where we showed that air pollution, how it's influencing, especially in parts of urban India, including Delhi. The risk factors were best propounded upon by the two important studies, inter-heart study and inter-stroke study. These were one of the largest studies, but before I come to that, we all know this algorithm that CVD epidemic in India is not only primarily happening because of the population level changes, but there is a complex interplay of biological risk. We all often see that if the father had an MI at 50, the son would come at 40. Very often you would see a patient of diabetes who had his father had onset of diabetes in 60s and son has come with type 2 diabetes at 40s. This genetic biological risk is also not genetically eugenics, but also the reverse of the same can happen in disorders as you encompass and treat these multiple disorders. And there are six major transitions that as a society we are facing: epidemiological, demographic, environmental, socio-cultural, nutritional, and economic, which also includes not only that we turn urbanized in our living, but move away from what was the standard of care, which now the West intends to look and reach back to the so-called rural living sit that is now the proposed away from the pollution kind of a scenario. It's the fetal programming that actually the genetics that drives the programmed individual, but there is also epigenetic early life determinants, which has been taught as even a baby born out of cesarean section getting more likely episodes of inflammatory disorders like asthma as compared to a normal vaginally delivered child. A lot of this is also coming into programming the individuals with the environmental trigger to a development of intermediate phenotype with metabolic syndrome, leading to development of CVD with high mortality. We also know that in women, especially this is a paper from Journal of American College of Cardiology in 2020, how the traditional risk factor apart: adverse pregnancy outcomes, autoimmune disorders, CKD, chest wall radiation, cardiotoxic chemotherapy, premature menopause, menopausal hormone therapy, PCOS, obesity, and cardiometabolic risk factors also influence. And a complex interplay of these, apart from the ethnicity, which being an Indian makes you twice as likely of risk of CVD as compared to a Caucasian counterpart. Apart from the income, zip code also, with the data sciences telling you that if your pin code is 52 rather than 22 in Delhi, you are probably more likely to have coronary risk disease than the other counterparts. Even depression, anxiety, loneliness, perceived stress, and we recently published how long COVID, so called beyond the index episode, may also influence occurrence of CV disease. Endothelial dysfunction and inflammation is the missing link, which leads to myocardial infarction, heart failure, stroke, and sudden death. This we know from QRIS 3, that if you're overall South Asian, your risk is twice. So Pakistani, Bangladeshi, or Indians, all we have higher risk. This is 4 times for Bangladeshi, thrice for a Pakistani, twice for an Indian. It's you may feel better that they get more hits, but still we are not even safer than them. Sri Lanka also has twice, and risk factors: dyslipidemia, physical activity, maternal specific risk factors, social determinants of health. This is the South Asian population assessed in US. This is the population that has already been born in US. They've been adapted to the environmental upbringing and the social and cultural sets of that country, but still we are at twice the risk as compared to their Caucasian counterparts. And this you need to then personalize. You look at the coronary artery calcium score, you look at the optimizing the culturally tailored lifestyle optimization, which includes diet, as well as the economic barriers, etc., on healthy policy apart from the data, population health, and religious context. This is our paper where we looked at the various coronary scores. So we have so many scores to evaluate coronary artery disease and risk factors. You have QRIS-3, you have ASCVD, you have Framingham. Which one does suit us the best? This paper we published in journal Saudi Heart Association, where we looked at 1213 patients undergoing coronary angiogram when they presented to cath lab for evaluation. We found out that even the best of the best score, which in our case turned out to be QRIS-3, also could not pick up more than two-thirds of the patient, which means we need our own data sets to tailor and engineer and develop our own algorithms to predict coronary artery disease. Huge amount of two-thirds or one-third of patients would not be picked up for obstructive coronary artery disease presenting with to the cath labs for an angiogram, despite all the scores that are available. Now, coming to the two most basic important studies: Interheart study, which looked at MI, Interstroke study, which looked at strokes. 52 countries, more than 1 million patients, and that's how they found out which risk factor contributes how much to development of coronary artery disease. Hypertension contributes 17.9%, smoking 35.7%, diabetes 9.9%, obesity 20%, psychological stress 32%, and dietary factors 13.7%, compared to stroke, where the prevalence rate was different. Hypertension was twice prevalent, smoking was half, and physical inactivity was considered as an important predictor in interstroke but not in interheart study. The Indian studies as well. We know India B study for diabetes. We also know India Heart Watch study, Kerala model studies, and Gladstetzer's study, where they looked at the prevalence of hypertension being high in certain states like Punjab and Kerala. This is the data sets, how they look. The reds are bad, the blues are not so bad, but that's probably underreported. I would be surprised to know that if Uttar Pradesh had prevalence of less than 9% of hypertension. But very importantly, we now also have certain other terminologies, which is cardiometabolic based chronic disease, or what you call as ABCD, adiposity or dyslipidemic driver, which is again an interplay of genetics, environmental behavior, and the beta cell dysfunction then coming in play, leading to hypertension, dyslipidemia, and subclinical coronary artery disease, which later on manifest with from asymptomatic to symptomatic coronary artery disease. So the insulin sensitivity and resistance, and then biomechanical and psychological complication, with all the primordial, primary, and secondary prevention elucidated here. I'm not touching upon the primary in this slide, but tertiary and secondary prevention, where you would look not only at the weight loss and activity increase, but also cardioprotective and renoprotective therapies to be intervened so that the events are prevented. So we have to go back to primordial prevention of risk factor. That's where we need to be. If you're talking about primary prevention, it would be just the high risk and prevent one from getting a CV disease. From that point of view, it would also require tackling social determinants of health, healthcare financing, smoking, being rather than charged, it has to be stopped. That's the way you probably can look into the same. There are various ways to intervene in this aspect: nurses, paramedics, validated non-invasive scores, as I mentioned, with the cardiovascular risk or for diabetes, low risk for both, and family history, and lifestyle advice reiterated every 3 to 5 years, and assessments of A1C and lipid, apart from the LFT, etc., from fatty liver. So how much difference does these risk factor in totality can bring? If we bring down total cholesterol by half, you can with 50%, you can actually decrease the risk by 50%. Blood pressure reduction only of 6 millimeters as a community on an average. If it is reduced in diastolic, it will reduce heart disease by 16% and 42% the stroke rates. BMI change, you maintain ideal, then it can bring down by 35 to 55%. Physical activity, 150 minutes of a week, which is recommended by WHO, brings down by 35 to 55%. Fruits and vegetables of 5 servings brings it down by 20 to 25%. And when you combine all of them together, they can bring down the event rates by 90 to 95%. Now, this can only happen if it's brought down to the community level at large. One individual doing these activity to reduce his event rates by 90-95% may not hold true because of our different genetic susceptibilities and priming. So where does this bring us to primary prevention as to what can be done? There are huge programs like National Program of Prevention and Control of Cancer, Diabetes, and Cardiovascular Disease and Stroke, where the hub and spoke model is proposed, and that's we also are a part of at UN Mehta Institute of Cardiology at Civil Hospital, BJ Medical College. We are the hub, and we have spokes, which are the tertiary and the other district hospitals. The government proposes to reduce 25% by 2025. That was what was addressed to be supposed to be done, but unfortunately that never happened. We all know that post COVID, instead probably we have jumped by 25% rather than reducing this by 25%. So what's problem? Problem is awareness and education. We'll have this discussion here, and then we'll go out to one of the booths to have the chocolate flavored new kind of a fruity ice cream that's available just opposite the counter of this hall, and then focus on generating awareness about lifestyle and other factors through community outreach programs is something that only happens between doctors. But community talks, we all need to wonder how many talks we delivered in communities compared to talking to our peer in conferences like this. Screening and early diagnosis remains a big challenge. Most of the patients, they think they are healthy. Diseases can happen to others, not to me. And that attitude that you are also susceptible and not invincible is something that needs to be propagated through public media. Lifestyle modification programs, as I mentioned, promoting not only fruits, vegetables, and whole grain. Wonder how many advertisements did you see in any live soap opera for talking about fresh vegetables compared to maybe a pizza, burger, or a food chain. Physical activity promotion initiatives, maybe now we are talking about marathon runs and then people collapsing in marathon. That makes a bigger headlines rather than somebody taking a early morning jogging and reducing his event rates. Community-based intervention should include school-based programs because that's where you cultivate early habits of good eating and good living. And that's something that's missing because most of our programs right now are focused on echocardiographic evaluation of presence of congenital heart disease rather than training them to avoid inappropriate lifestyle measures. Policy level interventions, especially as I mentioned about tobacco and alcohol, strengthening laws around the tobacco use. You may have the largest banner mentioning tobacco causes cancer, but that's also the way probably people take it as an advertisement rather than and a challenge rather than a debarring kind of a message that they should not be smoking. Integration of healthcare services is something that's very important. We need to integrate a conference like this, and I thank Dr. Bansi and the organizers of Diabetes World Conference that a cardiologist is talking about preventive strategies from cardiovascular health. If you're just going to focus on diabetes alone, perhaps that's not going to be the reach. It's time that a specialist or a super specialist also becomes some amount of generalist. Cardiologists also need to think about as a physician first, because once I became DM cardiology, I did not surrender my MD medicine degree. Research and data collection is a big challenge in our part of the world. We all have good amount and huge amount of data sets. Our problem is publishing it. And why? Because there is no incentive in either of the ways that you publish and you get incentivized for him. Unless we incentivize the research and data publication, the ABCD framework is not going to work. The ABCD is avoid alcohol, control blood pressure, control cholesterol and cigarettes, control diabetes, and exercise. The algorithm for healthcare innovation, hence, would run in future with a complex decision-making process where the innovation has to go through promoters before it becomes adopted as a strategy. And for that to happen, probably the stakeholders and the innovators need to become promoters. If a doctor himself is not a promoter of the science that he believes in, it's not going to make the day for itself. Because next step top 10 innovations that are anticipated by this year are going to be about capturing, identifying, stratifying, informing, taking decision and making decision about ecosystems of data sciences. The data sciences in medical care, I believe doctors do better than engineers or data scientists, because you know what matters most. You would hear very stupid kind of innovations happening, that somebody says that they take a photograph of your face and tell you what is your blood pressure. What this guy has probably done is taken a correlation between two non-significant parameters like color of your skin and measures and the values of blood pressure. But we as a doctor know that these are not significant correlating parameters. You know what will probably correlate, maybe the arteriolar pulsations in the retina. The top 10 innovation hence would probably be next in decade be looking at the medical tricorder, digital avatars, 3D printed medical devices, prostheses, surveillance tools, AI precision medicine, embedded sensors, and bioprinted sensors with regenerative medicine chipping in. In next 10 years, if maybe we will not have mortality by choice, but longevity will surely by choice. And in 2030, 97% of the doctors have agreed that AI is going to take your keyboard away. By 83% believe that AI will help patients diagnose their own disorders. And hence, the intellectuals of us who became doctors because we thought we was the most intellectual people should be not frying upon making a diagnosis, but rather strategizing how these algorithms can be used in primary prevention ahead of rest of the things. And of course, they say that that may be optional by 2040, especially if you can afford it. Thank you very much.